Today I'll be talking about initial opioid use leading to abuse, specifically iatrogenic addiction. The problem I'll be focusing on is prescription opioid abuse in the United States. It's reported that more people died of overdoses in 2014 than any year before, and 60% of these overdoses involved an opioid. It's estimated that 91 Americans die every day from an opioid overdose, and many of these people are introduced to opioids through prescriptions for pain treatment. According to the CDC, every day, more than 1,000 people are treated in emergency departments for not using prescription opioids as directed, and nearly half of all opioid overdose deaths involved a prescription opioid. Specifically looking at emergency department prescribing practices, it's found that prescriptions are usually for small doses. The median number of pills, according to the Brigham and Women's Hospital, was 15 per prescription. They studied 19 emergency departments over 1 week and found that about 3,000 out of 27,000 patients received an opioid prescription. The most common reason was for non-cancer unseen pain, like back pain, which means that they could not be proved and patients may have been lying in order to receive a prescription. So there are a couple ways that people are commonly introduced to non-medical usage of prescription opioids. These include treatments for acute and chronic pain leading to long-term abusive use, recreational usage, and transition from other opioids like heroin. In a 2016 study by Butler et al., emergency department prescription opioids as an initial exposure preceding addiction attempted to fill a gap in the field. They said that how opioid prescribing leads to abuse is not well characterized. Their hypothesis is initial exposure to opioids by emergency departments related to subsequent opioid misuse. They were specifically looking at iatrogenic addiction, which is when the legitimate use of prescription drugs, whether in the short term or the long term, leads to substance abuse. Their data was a convenient sample of patients at their teaching hospital with reported heroin or non-medical opioid use. Out of the 122 selected, 79 were eligible and 59 completed the survey. Their statistical method was a cross-sectional study that utilized a survey. There were some limitations, however. The sample was very small and dependent upon self-reporting, which risked the social desirability bias. They found that out of the 59 participants with the heroin or non-medical opioid abuse that first completed the survey, 59% reported being exposed to opioids by a legitimate medical prescription. 80% of these medically exposed subjects reported having a substance use disorder before initial opioid exposure. 29% reported that their prescription was received from an emergency department. So what does this mean? Before medical prescriptions for opioids are given, even in short courses like in emergency departments, precautions to ensure that the prescription will not contribute to addiction must be taken. This study helps to show where the research in the field is lacking, specifically the long-term risks of short-course opioid therapy. Once more research is done, policy can and should be revised to control short-term therapy so that it's less likely to contribute to addiction. Personally, this preliminary research suggests that more screening of prior substance use disorders is necessary.